for introductions, as Layla said, my name is Malla Keefe. I am a third-year family medicine resident at Cervical Health, and I am looking forward to speaking with you all today about some kind of recent changes and upcoming advancements in cervical cancer screening, specifically regarding self-collected primary HPV-based testing. I chose this topic because I care a lot about preventative health and women's health, and recognize that the pelvic exam, despite its utility, I think has a long history of whether it be emotional trauma, discomfort, or pain for some. And so the kind of recent changes seems like it might open up an opportunity for women to kind of reclaim some control over their bodies while still accessing routine preventative screenings. So let's see. I have nothing to disclose, no financial disclosures. I will note that so the market for primary HPV-based testing is actually still pretty small. There are just a few FDA-approved tests available that we're using. There are some new developments. I will name and discuss some of the specific tests and testing companies today. I'm certainly not paid by any of them, but I think it's helpful to be aware of the specific testing options when thinking about navigating the logistics of implementing these new testing methods and technologies into our practice. And then the only other disclaimer that I want to add is regarding language. While the majority of patients affected by this change are women, and some of the language that I use will suggest this, I do want to recognize that this more broadly affects anybody with a cervix and uterus, regardless of their gender identity. So these are my main objectives for today's talk. My goal is that you'll be able to leave here today with a solid understanding of the current guidelines for cervical cancer screening, as well as what's on the horizon regarding potential implementation of self-collected HPV testing and also the data supporting it. I'll also take some time to recognize how current screening methods contribute to health disparities and some of the broader kind of global efforts to move towards a goal of elimination of cervical cancer for all. So stepping back broadly, cervical cancer certainly isn't one of the most common cancers in the US or the world. It's currently the fourth most common cause of cancer affecting women or people with a cervix or uterus. However, despite having a vaccine against HPV and good screening techniques, the American Cancer Society is still predicting that we'll see nearly 14,000 cases of invasive cervical cancer in the US this year, and that 4,300 people will die from it. I think, as many folks know, kind of the number one risk factor for development of cervical cancer is persistent untreated HPV infection. And it is slow growing. It typically takes 15 to 20 years for abnormal cells to develop into cancer. But in the setting of recognizing that in the setting of an immunocompromised state, this can be as fast as 5 to 10 years. So again, despite pretty good screening techniques in place, which I'll talk about, we have seen a slight increase in incidence, kind of namely that age range from 30 to 44. So a lot of these folks didn't necessarily get the HPV vaccine when they were younger. We are seeing an incidence rate increasing 1.7% annually in the past decade or so. And interestingly, this correlates with we're seeing an increased percentage of patients who are considered un or under screened. So it was down to 14% back in 2005. So we were seeing really good screening rates. And we saw that rise to 23% in 2019. And now we're seeing some sources are citing almost 30% of individuals who are either un or under screened as of this year. So there was a study in 2022 kind of reflecting on why this shift was happening. And the number one reason cited by patients was the number one barrier cited by patients was like lack of knowledge about screening or not knowing that they needed screening at all. And then I think it's important to name the fact that like many other cancers, cervical and other diseases, cervical cancer disproportionately affects folks in low and middle income countries. The WHO has kind of published that 94% of deaths related to cervical cancer in 2022 occurred in these low and middle income countries. And you can see on the map here on the right that kind of rates worldwide are generally much higher than in the US, with kind of Central and South Africa and some parts of South America being like disproportionately affected. And so that said, something I found really interesting, these kind of relatively low incidence of cervical cancer that we are familiar with today, is in thanks large part to the historical developments in screening practices in the last century. So back in the 1930s, cancers of the uterus and cervix were actually the leading cause of cancer deaths among women in the US, with a rate cited of 36 per 100,000 women dying from cervical cancer back in 1930. The pap smear was developed shortly thereafter, so that's what we're almost familiar with. It was put out it was introduced in 1941. And then we saw kind of much broader implementation of this test over the subsequent decades. And since then, we have seen amazing kind of responses with decline by more than 70% since the 1950s, and with the mortality rate identified at 7.2 per 100,000 in 1990. We do continue to see these rates, or historically, up until kind of recently, we were continuing to see the kind of mortality related to cervical cancer dropping. And then kind of, I don't know, can you all see my cursor? I'm not sure.
Yes, we can.
Okay, perfect. And then kind of in the last couple decades is when we've seen some of the biggest advancements is regarding high-risk HPV testing. So in 1999, HPV-based or HPV testing was approved at that point just for follow-up of certain cytologic findings, like ASCUS. And then in the subsequent couple decades or subsequent decade or so, we saw several new tests introduced. So the hybrid capture 2 is one of the HPV tests, Cervical, and then the Roche Cobas. These are all kind of primary HPV tests. And then it was in 2014 when high risk, like primary HPV testing without cytology was approved by the FDA. And then in 2020, it's not called out here on this timeline, but that's actually when the American Cancer Society started recommending primary HPV testing as the preferred screening option over cytology, which I'll talk about shortly. But despite these recommendations, I'd say primary HPV-based screening is still gaining traction, largely related to kind of some of the limited availability of FDA-approved testing, which I think we see here in Boise, which I'll also touch on as well. So after kind of looking back to the past, I think it's interesting to look forward to the future and kind of get a sense of what our goals are, where we're trying to go. And in 2020, the WHO kind of put out a big effort with a goal to eliminate cervical cancer within the next century, with their definition of that meaning reducing the number of new cases annually to 4 or fewer per 100,000. And to achieve this goal, they kind of identified a multi-pronged approach targeting 3 main pillars: vaccination, screening, and then response to positive screens and treatment. The specific goals kind of that are depicted here are considered the 90-70-90 targets that they're hoping to see achieved by the goal being these are achieved by 2030. So the first goal is to see 90% of young girls under the age of 15 to have them fully vaccinated against HPV. I think the HPV vaccination is a huge part of this conversation as well. It's a bit beyond the scope of this talk, but I will touch on it. And then the second goal is to screen 70% of women for cervical cancer by the age of 35, and then again by age 45. And I think the developments in this realm is what I'll address primarily today. And then finally, third, there's an effort towards providing treatment to 90% of women who are identified, or 90% of women with identified cancer or precancerous changes. And interestingly, Australia is the one country that's been highlighted as being on target to reach these goals by 2030 and potentially, quote unquote, eliminate cervical cancer by this definition. And then, as I, just discussed, there's a lot of, I think, health equity issues at play here, with 94% of cancer deaths occurring kind of in low and middle income countries, but then also kind of addressing the social determinants of health that are at play, not just globally, but also here nationwide, that contribute to these screening inequities and higher incidence of mortality rates in certain populations. And so just calling out folks who are, un or underinsured, people from who come from low socioeconomic backgrounds, racial and ethnic minorities, rural residents, transgender, gender nonconforming individuals, anybody with a physical disability that makes a pelvic exam, physically difficult potentially, people with a history of abuse or trauma, and specifically healthcare trauma, who understandably might avoid screening. And so I think that there's a lot of things at play that can affect somebody's either access to care or desire to accept screening if it's been offered. And so just something to keep in mind. And then I'll also note that kind of that last box there, anything that decreases access to in-person healthcare drastically affects screening rates. So one study by the CDC found that cervical cancer screening rates dropped by 80% during the stay-at-home order during the pandemic. Unfortunately, since then we've returned to pre-pandemic screening rates, but kind of recognizing the importance of in-person care for cervical cancer screening at this time, and recognizing that there's a potential for that to change. So I've laid a lot of groundwork where we're coming from, where we're heading towards, what our goals for the future are. And so let's just take a moment and review cervical cancer screening guidelines. Probably this is review for most, but the recommendations from the United States Preventative Services Task Force, or the USPSTF, kind of vary based on age group and then also kind of different types of testing. So the current recommendation is screening for folks ages 21 to 29 every 3 years with cytology alone. And then from ages 30 to 65, the recommendation is, again, cytology alone every 3 years. Primary HPV testing alone every 5 years, or co-testing with cytology and high-risk HPV testing every 5 years. I will note, though, that or recognize that there are other professional societies that have other recommendations. I think I already alluded to the American Cancer Society's recommendations, which is just to begin screening actually at 25 rather than 21, and screen all individuals from 25 to 65 with a primary HPV test every 5 years. So they really put a lot more emphasis on that primary HPV testing. And so what that testing looks like is kind of at the forefront of some of the recent and upcoming developments that I want to speak with you about today. So I'd say the big change, the big thing that we're talking about is moving towards self-collected vaginal samples for primary HPV testing. We already use self-collected samples for other assessments, whether it be STD testing, like looking for yeast, BV, et cetera. And the proposed collection method is essentially the same. These instructions here on this slide are out of our Australia's directions or recommendations for self-collection. And so basically just simply inserting the swab about 3 inches into the vagina, rotating 1 to 3 times, and then removing it. And this has been identified as adequate for HPV detection. And we'll kind of dive into the data today. And so this is where I kind of want to name some of the specific tests. I think it's important for the logistics. So there's currently 2 primary HPV tests that are FDA approved. And this is an announcement from the FDA in May of this year when they expanded the indications of use for these 2 tests to include, and so I highlighted here, it includes a self-collected vaginal swab, but under very specific circumstances. They say in a healthcare setting, when the patient and the healthcare provider determine that it is not possible for the clinician to collect a cervical specimen. So it opens up the door for self-collection, but I think that they're hesitant to kind of approve it formally for broader use. And then the 2 tests that are named here that got this approval are the BD on Clarity HPV assay and the Roche Cobas HPV test. The first one, the on Clarity, it does genotyping for 6 high-risk strains. So it captures 16 and 18, which are kind of the ones people are most familiar with, as well as 31, 45, 51, and 52. And then the Roche Cobas test does genotyping for 16 and 18, and then pooled testing for 12 additional high-risk strains without genotyping. And so this development was picked up by mainstream media. There was an article published in the New York Times in August of this past year highlighting kind of this change and some other upcoming changes. And in this article, the author discussed the likelihood of possibly shifting towards self-collected testing in the future, whether it be in a healthcare setting or potentially outside in the home. And so I think that with broader coverage like this and this potential change, I wouldn't be surprised if folks start getting questions from patients. And I think that it's important that hopefully today this talk will provide adequate background so that you all can counsel your patients on kind of where we're at and where we're going. So I guess I want to take a step back and make sure that I kind of delineate really clearly what the shifts are and what we've seen thus far and what we haven't. So first, there was kind of the move towards primary HPV testing as kind of the primary recommendation for screening. And as I talked about, that's already happened. The ACS, recommends this. The USPSTF supports it. And so as we're seeing more access to primary HPV testing, hopefully that availability or accessibility will improve. And then there's the movement towards self-collected HPV testing in the office. So again, under certain circumstances, the FDA has approved use of self-collection in the office. And then there's this whole next movement towards self-collection in the home, so outside of a healthcare setting. And to be clear, this has not been approved in any setting in the US at this point. But it does seem like a pretty small jump. So if we can prove that self-collection in a healthcare setting is adequate, getting a sample at home doesn't seem so far off. And to me personally, and I think kind of the broader public, recognizing that this advancement in home testing would probably seems like it would have the greatest impact in reaching un- and under-screened individuals, as it could allow us to reach out to people who potentially never make it into a clinician's office. So in the realm of home self-collection, there's several companies that are trying to create products that increase the ease and accessibility of sample collection. So there is just a standard swab, which to many feels perfectly easy to use, but then there are, like I said, other companies that are developing specific products. So this is I just wanted to give one example. This one's called the Teal Wand, and again, it's a trademark collection method that would take that sample and it would still run that sample using the existing FDA approved primary HPV tests like produced by BD and Roche that I talked about. So this is really just a sampling method. And in May of this year, the FDA granted this particular device breakthrough device designation, which doesn't mean that it's approved, but means that they're going to expedite the review process, which again I think just points to the recognition that there are opportunities for advancement here. And then I just want to highlight that this is, we would be far from the first country to initiate self-collection for primary HPV testing for cervical cancer. The map here on the right shows several countries that are in different stages of use of and approval of self-collect primary HPV testing. So the countries in orange, though some of them are very small, there are several, and these are the countries that have implemented, again, self-collection primary HPV testing for all individuals. So that includes the Netherlands, Albania, Kenya, Rwanda, Guatemala, Peru, and Malaysia. And then there are several countries who have approved self-collection for under-screened individuals, so folks who aren't up to date on their screening or have kind of been lost to follow up. And those are the the countries highlighted in yellow. So Denmark, Finland, France, and Sweden, Australia, Argentina, and Honduras are all in that stage. And then there are several countries highlighted with an asterisk, and these are countries that are piloting this process. So that includes Greece, Italy, Spain, Portugal, the UK, Canada, New Zealand is on there, Mexico, and El Salvador. So I think that this is, and a lot of these shifts have happened in the last really 5 to 10 years. So we would not be alone. I will highlight, so we're green along with several other countries. Those are just the countries that have HPV-based screening alone, but have not kind of made a large state, like made a statement or a recommendation for self-sampling. And so now I want to take kind of several minutes to review the data behind this. I think my overall takeaway is that the initial data wasn't great, but that we've seen a lot of changes over the past couple decades. And now we're seeing that the accuracy is largely equivalent. So the first kind of the initial evidence for this so specifically self-collected testing, there was an early meta-analysis in 2005, and kind of in interpreting the data, the kind of conclusions and findings here, it's important to recognize that the context of this study, so this was shortly after primary HPV testing was approved for screening, and before the PCR-based tests that we primarily use today, the ones that are FDA approved today, these really weren't developed yet or used. And so kind of the testing methods that were assessed at that time were very different. And this study in 2005 showed a sensitivity of self-collection samples to be about 70%, which is really not ideal given that an initial screening test, given that the sensitivity of physician-collected primary HPV testing, at least today, is upwards of 90%, and some even quote like upwards of 98%. So really not nearly as sensitive. And then 2012, there was another meta-analysis that looked at this again, that did show similar sensitivities and specificities between self-collected samples and clinician-collected samples, but it identified several limiting factors. It sounds like kind of the studies that existed, there's a lot of heterogeneity in kind of the testing methods. So again, the sample, like how the sample was collected, and then what test was used to run the sample. And then also just they named kind of a relatively low incidence of CIN2 or greater in the populations that they looked at. So I will note, kind of moving forward, the CIN2 and greater is kind of generally used as the cutoff of what we're hoping to detect with this kind of shift in testing. And so then there were two additional studies that I'll address that seem to me to provide kind of the best representation of the current literature. They were both produced by the same group, one in 2014 and one in 2018, with the latter that I'll discuss in a minute, seeming to be kind of the most useful data at this point. So interestingly, this study in 2014 basically concluded that both the self samples were both less sensitive and less specific than clinician collected samples. But they kind of picked up on a key confounding factor, which I think explains why maybe some of the data up until this point wasn't as supportive. And mainly it was looking at the difference between the PCR and the signal-based assays. And so without getting too much into the weeds of like testing methodologies, basically the earlier tests, so like one example is that hybrid capture 2, that was one of the first ones. This used a different method for sample analysis and didn't allow for genotyping, whereas the PCR-based tests do. So they identified in this particular study that the PCR-based test, such as like the BD on Clarity and the Roche COBAS that I talked about, were more promising. And so then in 2018, they published another study pooling the PCR-based testing and the signal-based assays separately. And they looked at, was a meta-analysis looking at 56 accuracy studies. And it basically showed no difference in the sensitivity between self-collected and clinician-collected samples. The specificity was slightly less, and it was statistically significantly so, but it was really quite close. And ultimately, they found the pooled kind of sensitivity for the high-risk HPV PCR tests for CIN2 and greater to be 96 with a specificity of 79, and this was regardless of collection method. So this is like, it's a lot of data, and it's how important is it to know where I think it's important to know where we came from and why maybe it initially didn't look as promising, but recognizing today that there really is pretty decent data, at least that we have so far, supporting that self-sampling can be really quite accurate. And then after kind of considering the accuracy of the self-collected samples, I think it's also really critical to think about what's been called kind of the acceptability of the test. So even if it were less sensitive, if self-collection allows for more individuals to be screened than would otherwise be reached, this could ultimately lead to improved overall detection rates. I was not surprised to find that basically every large-scale study demonstrated increased like better acceptance of self-collected samples over clinician-collected samples. The meta-analysis here from 2019, this one included 33 randomized controlled trials and showed significantly greater screening uptake among HPV or much greater screening uptake for HPV self-sampling compared with the control. And then the 2018 study I'm referencing here is actually the same as this one. They had they also assessed acceptability within kind of the studies that they looked at, and they had identified that among like the directly offering self-sampling to folks who are underscreened led to really high participation rates of greater than 75%. There was one study that did identify kind of, or look into the concerns of why people might not want self-sampling. And the kind of primary issue that was identified among folks who opted for clinician collected samples was that they were worried about their ability to collect an adequate sample for accurate results. However, I think that all of the data we just reviewed on the previous slide supports the fact that if they follow the recommended instructions, that the testing really should be accurate, and that patients could likely be kind of counseled with this, that they should be able to achieve kind of accurate results with their sampling. So cost is another big consideration here. There's really not a lot of data on this. A few countries, England, Sweden, and Uganda, have published some cost analyses that generally suggest that it's cost effective, but we really have nothing in the US or within our healthcare system to assess it at this point. I did find it interesting. There was one study that identified or that referred to kind of a broader public health strategy where they utilized community health workers or CHWs to reach out and disseminate self-collected HPV tests. And by bypassing the need for clinician involvement or a visit necessarily, this with like that initial screening phase, it led to significant cost savings. And I think this might have been out of Uganda potentially. And then there's one other consideration. Well, there's many, but one other consideration that I really don't have much data on, and so I don't have a slide on it, is thinking about potential harms of screening. So, you know, is it possible that if we're going to have more positive tests, could that lead to more invasive testing, such as like follow-up colposcopy? But in my mind, generally, like if the data is supporting similar sensitivities and specificities between self-collection and clinician collected samples, then theoretically there really shouldn't be much a difference in this particular harm. And so I tried to find all the data that I could regarding self-collection, but there's definitely a recognition that we don't have enough data yet to support like self-sampling broadly, but it's looking optimistic. So the National Cancer Institute earlier this year in January announced something that they call the Last Mile Initiative, which is a partnership between federal agencies, industry, professional societies, and their basically explicit goal is to gather data to overcome what they say is the barrier of lack of FDA approval for self-collection approaches for HPV-based testing. And so it specifically names, like it identifies that self-collection samples seem to be kind of the primary route that is seen as like improving cervical cancer screening, and thus lowering the incidence of cervical cancer. So through this initiative, they've started the SHIP trial. This stands for self-collection for HPV testing to improve cervical cancer prevention. And the study is now underway. It's US based, it's nationwide, multi-center. You can see kind of some of the locations that are enrolling patients now as of this past summer. And again, we're kind of assessing the self-collection in kind of multiple different realms. So they identify, so there's kind of the idea is, you know, parallel evaluations across multiple different locations of these in these different realms. The first being kind of usability and acceptability. So I think I talked, you know, I talked explicitly about acceptability today. Usability is kind of thinking about how easy is it for patients to obtain a sample, and then, you know, how willing are they to do so. And then looking at the accuracy. So again, we have some data for it, but definitely need more. And in this realm, they're kind of looking at different combinations of self-collection devices and also HPV tests or assays. So as far as collection devices, again, this is like a basic swab versus the teal one versus, you know, whatever else they're coming out with. And then looking at the different assays. So again, the primary ones being the BD-on Clarity and the Roche COBAS tests. And then looking at the effectiveness of reaching un- and under-screened individuals and people at higher risk. So really, in my mind, it's like how much of a difference is self-sampling going to make in the efforts to rectify kind of some of the historic inequities in screening. And so with that in mind, kind of looking at the USPSTF updates, they continue to flag that the cervical cancer screening guidelines are under review, and it's identified as being in kind of the final research stage. So they propose some key questions that they need answered, and I think that the kind of answers that that will hopefully come out of the SHIP trial will map directly to these. I think some of the key ones here are, again, what is the accuracy of vaginal samples for primary HPV testing, and what is the kind of effectiveness of different screening strategies on detection, morbidity, and mortality. And then they also recognize a couple kind of key unanswered questions that they call kind of contextual questions. So kind of, again, inquiring about current, specifically like racial disparities and increased incidence and mortality of cervical cancer, and how can we rectify this? So again, all things that hopefully the SHIP trial will be able to kind of give us some more information about. And then I think there's several more considerations, but these are just a few that I think are really important to think about when, again, potentially implementing this into practice at some point in the future. So I think that this could end up playing a variable role, and I don't think we know just yet what that's going to look like. So there's a world on one extreme where this largely replaces clinician-performed pelvic exams and that we just move entirely towards like recommending self-sampling as like a primary method for screening. I think probably more likely what we're going to see is something kind of in the middle, where maybe it's approved for or under-screened individuals, like we've seen in many other countries. I think from what I've read, it seems unlikely that it won't be approved at all, but I can't see the future. I don't know what the SHIP trial will end up showing. And then the kind of second point here. So I think that this in a lot of ways maps to things like, we use the PSA for prostate cancer screening, we use stool-based testing for colon cancer screening. And so this, I think, is very similar, right? If you have if we have a positive result on the initial screening test, this means follow up with, either whether it be a pelvic exam for a clinician collected sample or colposcopy, but that would be the recommendation. And so if this were approved, I think it'd be important to kind of discuss this or include this as a caveat when talking about sampling or like testing screening options with patients. And then finally, I think that as I mentioned before, primary HPV-based testing, at least in our community, isn't as broadly available as I would have expected it to be. So, and so we need kind of the systems, the kind of lab resources, we need workflow, we need things in place to help reach more people if this change does occur, and thinking about kind of the logistics. So at least my understanding, and I definitely welcome anybody else's thoughts if they have updates, but kind of in the Boise community, as far as I'm aware, there's really just one lab in the community, Express Labs, that runs the BD on Clarity test specifically. And I know that within Full Circle Health, there have been kind of barriers to creating like a resulting platform if we were to use them. And so thus far, it really hasn't been an option in our clinic system, but last I heard, I think St. Luke's was considering adding this to their lab, which would greatly improve access to this testing within our clinic system and in the broader community. But I think, again, thinking about the logistics of how this would be rolled out will be really important. And then I think that really this presentation wouldn't be complete without at least briefly discussing the importance of HPV vaccination. So really, screening and vaccination are both kind of methods of primary prevention, but vaccination ideally is kind of our first line of defense in cervical cancer prevention. So and also kind of thinking about the fact that, again, kind of harkening back to the WHO's goal of having 90% of girls under the age of 15 vaccinated, that will require a big push from where we are today, specifically in the US. So there was initially the quadrivalent vaccine back in the early 2000s, and then the nonavalent vaccine was approved in 2014, and that's the one that we're primarily using today. There are a lot of studies promoting or demonstrating the efficacy of this kind of vaccination intervention. And I found this kind of graphic particularly interesting. Comes from a study out of Sweden. It was kind of a nationwide kind of population study looking at 1.6 million girls and women between ages 10 to 30 from years 2006 to 2017, and comparing those who had received the HPV vaccine to those who hadn't. And by let's see. And so the cumulative incidence was 94 cases per 100,000 among unvaccinated individuals, and remained stable at 4 cases per 100,000 individuals by 28 years of age, which for those who are specifically vaccinated at a young age, less than 17. So I think that this just, again, kind of supports the importance of vaccination, and particularly, I mean, the HPV vaccine is kind of our only vaccine that prevents cancer. So always important to plug that for our younger folks. And then the map on the right, this comes from the CDC. This demonstrates HPV vaccination rates. This is from 2022. The nationwide vaccination rate was about 63%. And I was actually pleasantly surprised to see that looks like we in Idaho kind of fall into the 62 to 73% category. So really kind of on par with the nation average, which is good. But all of this said, I think that, ideally with improved worldwide vaccination against HPV, maybe at some point way down the road, we'll be able to even decentralize the need for screening in the long run. But I think we're far off from there. So kind of in summary, I think if you take one thing away from this talk today, I just want people to be aware of the fact that the FDA has approved in-office self-collection for, again, in very specific circumstances. So in the office, and if the patient and provider have deemed it like not possible to get a cervical sample otherwise, but recognizing that there's a lot of research happening in this realm right now, and it would really not be a surprise if we saw kind of some element of self-collection approved, I think as early as, in the next year, but potentially more depending on kind of the timeline of these studies. So I'd say, continue to keep an ear out for updates as this research is published. I think that, as I said, the evidence thus far, I think really does support the accuracy and efficacy and acceptability of this testing over kind of a pelvic exam-based, in-office collection, but we will see. And then I think that the kind of last thing is, again, just clearly recognizing the applications of this potential development could really help us reach kind of historically and under-screened individuals and have big impacts on kind of health disparities, both in our country and worldwide. I think that's it. I have a couple of reference slides. I welcome questions. I'm also very curious to hear if anybody in the community or anybody on here has kind of been using primary HPV testing in their practice, and if they've explored kind of using the in-office kind of self-collected sampling for anybody, or if there's been any opportunities to try that.
Malla, I just have a question for you. I mean, first of all, that was an excellent talk. Really enjoyed the historical perspective on that, and sort of where we're going with it. And I have two questions. One, logistically, when they're doing self-screening, is it in these countries that are really implementing it, are they having, using the community health worker where they're actually standing there waiting for them to collect and then take it back? Because I wonder about the capture rate of those self-collected swabs. And then second part of that is, what have like the studies or information shown that they've actually had an increase in the screening for those underserved areas, the countries that are really just targeting that spot, like has this been beneficial for them to promote this and fund it for those countries?
Yeah. So first question was kind of regarding like the capture rate of these self samples. It's really hard because there's so much like heterogeneity between, like, every country has a different method. And I ended up on like websites of multiple different kind of public health kind of organizations for some of these different countries. I think so I really can't speak to like on a whole. I think there's a spectrum. I think some are doing, at least my understanding is, I think some are doing like mail, like you can mail it. I don't think it has to be done necessarily like in an office. I think some are doing it in the office. Australia, they just rolled this out in July of 2022. I think they're primarily doing it in the office right now. But yeah, I think that the majority, especially for the kind of like low and middle income countries that have already rolled it out, their goal is to reach more people. And so I think they're doing more of the mailing out and like outreach to try to reach more people in that way. But it's a really good question, and I can't give you like a definitive answer, to be perfectly honest. And then the other one you were saying was about it was regarding the acceptability, right? Sorry.
It was more on like, outcomes of doing this. Have they been able to increase their screening rates? Like, is this successful?
Yes. Yeah. I think that that's where, and again, I can't speak to each individual country, but that meta-analysis there's that group that published the paper in 2018. And they're like the general findings, kind of looking at all of those different studies, was that like they're on average, they reached like 75. They were able to like get samples from 75% of people who hadn't been screened before, which was way higher than I would have expected. And I could go back to the paper and kind of look at some of the kind of details of their methods again, but it was pretty impressive. And I don't know like what kind of follow-up, like there were different ways, right? You can mail it, you can call them, you can send letters. Like, I think that a lot of different places have tried a lot of different things. And so again, if we were to roll it out here, I don't know, I'd have to go back and see like which country has had like the most success, right? And which one is like the most similar to our patient population that we're trying to reach. And so I think that there's so many different factors, but I really liked this concept of like, well, can we use community health workers, especially in like, small communities, and as long as they have the information and the ability to like ask follow-up questions, like about, well, you might, if it's positive, what happens? But those questions don't necessarily need an office visit. And so this idea that we could potentially, I love seeing patients. I love talking about cervical cancer screening with them in the office, but like, if they don't need me, that's kind of great. Yeah. I hope that answers your question.
Yeah, no, that's perfect. Thanks. I figured that there may not be great answers to those, but it was
I
more
will
follow-up.
say more to come. Like obviously there's this big trial happening in the US, but there is a lot of like pretty high quality data out of the countries that are doing like pretty good quality data looking at this thus far. And it's just a matter of kind of diving into it. And in some ways, like I'm kind of curious to actually almost piece it out rather than looking at these meta-analyses, but kind of looking at the different countries and how they've rolled things out independently.
Dr. Blake has a question in the chat. It's, are there any cost proposals? What will be a cash price? How will patients access? Will there be direct to consumer marketing?
Yeah. In the US, as far as I'm aware from the research I was doing for this presentation, I am not aware of any of this information that I could find. I'm sure that I know Dr. Esplin's on this talk, and I know she's been kind of involved in looking at getting primary HPV testing to make it more accessible here within our clinic system. I don't know what like cost is looking like. I think yeah, I imagine that there's like the cost of, in the same way that we do other procedures now, right? There's the cost of the procedure and the cost of the test. And so if it's an in-home sample, like in my mind, then it's just the test cost. I don't know what the cost of what the costs are. And then as far as direct to consumer marketing, again, as far as I'm aware, I don't know if this has been addressed, but it would be really interesting. I mean, I would love to see more kind of direct to consumer kind of public health pushes in the US. I've been really impressed often when I travel abroad, seeing some other countries, how they just go directly to people and try to promote, you know, certain kinds of screenings. And I see a world in which that could potentially happen. I don't know. I don't know if that really answers your question. I think the answer is we don't know yet. I think we're still in the phase of, is this even like the right thing to be doing? Which I think generally the conclusion is yes, but we don't have enough to definitively say that yet. Great. Yeah, of course. Any other questions? Happy to chat offline too if other people have additional thoughts.